Good morning, Chicago. I'm Dr. Allison Arity, Commissioner at the Chicago Department of Public Health. Today is Tuesday, April 26, 2022, and we are pleased to be back and answering your questions. A number of you actually had non-COVID questions coming in this week, which I appreciate. We got some questions about Earth Day, which was a beautiful day here on Saturday over the weekend. And of course, CDPH works on environmental health issues. And actually, in a minute, I'm going to show you just a short video highlighting some of that work around tree equity, because people were wondering what was CDPH doing. And so I hope you all had a happy Earth Day. We also yesterday released some data about the life expectancy changes that we saw in 2020, the first year of the COVID pandemic here in Chicago. Not just COVID deaths, which of course we've been counting all along, but a lot of the indirect impacts of COVID. So I know you might have questions about that. I put a few slides together just to highlight some of those things. And then as always, we'll do a COVID overview, and we've also got COVID questions people have sent in, and we'll take your questions live. You'll be able to use the hashtag AskDrArity on either Facebook or Twitter, or put your questions directly into the box below. And just as a reminder, we are intending to keep this segment going Tuesdays at 11 a.m. unless otherwise noted. And as we're doing today, really we'll be expanding to talk about a lot of work at the health department that is in a beyond COVID kind of way. We'll keep talking about COVID for as long as it remains a concern. And trust me, we continue to put a lot of resources and effort into ensuring it remains in control and that we're prepared for any potential surges or changes. But in the meantime, it has been really nice to have some opportunity to work on other things. So let's actually start with the video that highlights some of the tree equity work related to the Earth Day. If we can go ahead and play that.
Trees are not just something that is nice to have. Now cities are increasingly recognizing that trees are critical infrastructure. Trees are these incredible workhorses for cities. They provide all of these different benefits. On the environmental side, trees actually cool the air, and they provide shade, which cools the ground. They clean the air. They improve air quality, which helps reduce things like asthma. They provide rainwater and stormwater management benefits. They suck water into the ground through their roots, which helps prevent worse flooding. On the economic side, tree-lined streets actually show higher economic returns for businesses. Commercial districts that have higher trees show higher receipts for businesses in those districts. And tree-lined residential streets actually increase property values. The longer that a tree lives, the more that it matures, the bigger the quantifiable, measurable benefits that it provides to a community. When you look at the maps in a city like Chicago of where there are less trees today, when you overlay that with historic maps from the redlining era, those are the same places that today are hotter, have worse public health conditions. And so when you overlay that data together, it provides a very, very clear picture. Tree canopy cover, the existing trees in cities, are often not evenly distributed throughout a city. Equity-focused tree planting means we're using data to target new tree planting and maintenance activities to the parts of the city that need that help the most. The Chicago Department of Public Health, through a grant from the Bloomberg Philanthropies Partnership for Healthy Cities, built a really cool new data and mapping tool that for the first time brings together data on public health issues, social vulnerability, and economic hardship, as well as infrastructural data. Tree planting has been a real way to get people involved in making a difference, and it's a real way for different groups to come together for the first time and start to collaborate and work together towards real, tangible climate solutions.
Enjoyed seeing that. Obviously, we thank Bloomberg both for the work in getting some of that work started, but also in helping to make some of the videos to tell the story there. One of the reasons that CDPH is very interested in trees is that it's an opportunity, of course, to work on environmental issues, but there's also good data that where spaces are more green, mental health is improved, there can be violence prevention outcomes. And so through the city's Community Safety Coordinating Center, there actually is some new work with the infrastructure departments, meaning streets and sanitation and some of the other really important departments that help keep our city clean, help keep our city moving, to make sure that in some of the parts of Chicago that have experienced the most violence, really on a block by block level, if there are vacant lots there, what can we do to clean and green some of those lots? There's some work in some of the most impacted neighborhoods to plant initial trees and think about who is doing uptake and how do we build community resiliency around that. And so we see it as both an investment in physical health, where we know that that improves public health outcomes, mental health, but also things like community cohesiveness and economic worth of homes and businesses in those neighborhoods. So Rayed Mansour, I actually had him on Facebook probably like in the last 6 months for sure, leads a lot of the work at CDPH around that. And we are really excited and thankful both for the new investments that have come as part of Chicago Recovery Plan and the American Rescue Plan dollars that are letting us jumpstart that, and the ability to use data and make sure that across the whole city we are looking at how to make us resilient from a physical and mental health perspective, but also in a long-term way from climate impacts. So I hope that helped answer some of the kind of long-term work that CDPH is doing related to Earth Day, and the city has a climate action plan that we of course have been part of pulling together, and this long-term work is really central to what we care about as a health department. So let's take a quick look at the COVID dashboard. We do continue to update it 5 days a week, Monday through Friday at 5 p.m., chai.gov/COVID-, and you'll see right up at the top, our COVID risk level does remain low. Reminder, this is using the CDC COVID community levels, low, medium, or high. And that is because although case numbers continue to increase, we're averaging 585 cases per day, and that's up 26% from a week ago. You can see that increase is really very gradual compared to what we saw with the big Omicron surge in January, much more consistent with what we saw with some smaller, earlier variants. And importantly, we are not seeing this surge, even after weeks and weeks of it. I wouldn't even call it a surge. I'd call it a little bit of a ripple as opposed to a wave. We're not seeing it turn into the severe outcomes like we did previously. So look at hospitalizations here, averaging 10 per day. That is near the lowest that we've ever been. It's consistent with where we were last summer. Deaths are the lowest they have ever been. We're averaging about 1 a week, 1 to 2 a week. And you know, if you look up, somebody was asking, where do I find out what's actually happening with hospitalizations? Every single day here under latest data, if you come to hospital capacity and click on it, you can see every day in Chicago at noon, we look and we see across the whole city how many ICU beds are occupied, how many non-ICU beds are occupied, how many ventilators are occupied, and then how many of those are COVID versus non-COVID, and even how many of those have diagnosed COVID versus a patient under investigation, meaning we're waiting for a COVID test to come back. So you can click on any of these if you want to see graphs or charts. But you know, if you go back to this table, what this is telling me that with the most recent update, just across the whole city here, first, we've got lots of capacity. Almost 20% of our ICU beds across the whole city are empty, and 18% of our non-ICU, that's very good. 71% of our ventilators are empty. And COVID is very little of what is in the hospital right now. You can see, even including both patients, diagnosed patients, and patients under investigation, like across the whole city, there's just 36 people in the ICU right now, 16 of which are known to have COVID, and 20 are usually people who have been newly admitted with some kind of respiratory failure, and they may have COVID, and so you don't count them as COVID until their test results come back, but we monitor that from a capacity standpoint. So really just 16 people in the ICU with diagnosed COVID, and just 9 of them on ventilators across the whole city. It's amazing, really, to see that kind of outcome, and most of that is because of vaccination. So really the news continues to be good on the severe outcome front. And then the last thing I'll just note on the dashboard here, let me take us back to the original, is a number of you were noting sort of what's happening with positivity. And I did just want to remind you here that we saw tests performed here. Let me just zoom out here. We saw a big drop in that test performed. That was the week that everybody was on spring break. Many of our schools were away. A lot of our testing is happening in schools. And so in that setting, we saw this big drop. It's now nearly back up. You can see there's been a continued decline, but it's more in line with what we've seen all along. And so in that setting, our positivity, as predicted, is back down. We were at 5.3% when we were taking into account that much lower testing, and we're back down to 3.8%. Which again is what we would expect because positive cases divided by all the tests performed. And so this is why, as we are using the community levels and looking at risk, positivity is not what we rely on to measure the impact of COVID illness. We look at is more about, are we testing enough? Do we have enough capacity in place? And here in Chicago, we are doing a good job still of testing, and everything is looking good. All right, so let me turn to some slides here. And okay, already somebody put in a sort of a follow-up question about the Earth Day stuff. Let me just go to view here. So yes, you can find out some more about this at Our Roots Chicago. So if you Google Our Roots Chicago, or there's a website at the bottom there, chicago.gov, et cetera, Our Roots Chicago, it tells you a little bit more about some of the planting tree work. And then there's some screenshots of the data tool. Again, looking at tree canopy coverage. Lots and lots of partners have been involved in pulling this together. And we're just now sort of getting into using it with departments and making decisions with community members. And it's exciting. Also, yes, yesterday we did, in fact, addressing some questions coming in about this, we had a roundtable discussion on the newly released data from yesterday on the declining life expectancy in Chicago. And so you can see we were down at Phalanx Family Services. That's down on the far south side. And that is our Healthy Chicago Equity Zone lead down there. As a reminder, the city, CDPH, we've divided the whole city into these 6 Healthy Chicago Equity Zones. There's a lead organization in each zone. That lead organization is funded, and then in turn they fund smaller community-based organizations in all of our community areas. And they've been working on vaccine work, but moving ahead, it'll be working on some of the other chronic disease and other long-standing health issues, really creating some infrastructure and workforce that can address the life expectancy gap, but then also be able to pivot if we have a surge, if we have another pandemic. And we're really excited about that model. It's unusual in Chicago, $30 million investment in these HCEZs directly in community. And so it was nice to be down there. And we were with Vaughn Bryant on the left, who leads a lot of the work on gun violence at Metropolitan Family Services, Metropolitan Peace Initiatives. And then Brenda Battle, who's at the University of Chicago, but does a lot of the South Side transformation work, where 13 different health providers on the South Side have come together to think more about how do they work collectively across health systems, across FQHCs. How do we think about making community health workers more at the center of how we reach people? How do we encourage folks to not use the emergency department for primary care, but actually get people connected to behavioral health and physical health needs where they live and have standards of care? That's me and the mayor. Chichi Okwu is with Everthrive Chicago, Everthrive, which is one of the organizations we've long worked with on maternal and child health. They also do a lot of vaccination equity work, and they've been instrumental in helping us get Family Connects launched, which is our what we hope to eventually be a universal nurse home visiting program, where eventually any time a baby is born in the city of Chicago, there is a nurse home visit that comes about 3 weeks after the baby's born, and we can talk a little more about that. But with Chicago Recovery recovery plan funding, we're excited to be able to hopefully expand that from our initial 4 to hopefully all 18 birthing hospitals in the city of Chicago, and have it be just part of the care, as more than 90% of Chicago families have unmet needs. And it's a really universal sort of public health approach, not waiting for somebody to have a problem and seek health care, but actually being able to go out, check mom's health, baby's health, and then importantly, what does the family need moving forward. And then finally on the right, Dr. Melissa Simon, who's at Northwestern, does a lot of health equity work. She's an OBGYN, so also very involved in our maternal child health, but also has been a leader on the provider front and generally with Illinois Unidos, which has come together during COVID and done a lot, I think, to really push in helpful ways, thinking about what do we need to do differently for Latino access and growth. And so it was a really interesting discussion. You're welcome to watch it live streamed. It's on the mayor's page if you like. This is the main thing we were discussing. So life expectancy in Chicago declined during the pandemic's first year. So this is 2020 data. And yes, right away, a couple of you were saying, why was this only about 2020? So we do count all of the people who die of COVID, for example, in pretty real time, as you know. So I already know how many people died of COVID in 2020 and 2021 and 2022. That might get adjusted a little bit as final death certificates get certified, but it doesn't move a whole lot. However, to be able to really understand all of the things that people have died from in Chicago, you have to wait for all of the death certificates to come in, get certified by the medical examiner. They go through a whole process. So this data typically comes out more than a year later. But it's the robust data that lets us understand more of not just direct causes, but indirect. So what we saw in black there was that between the year 2019 and 2020, Chicago lost basically 2 years of life expectancy. And that might not sound like a lot, but it is huge. We count life expectancy in 0.1 and 0.2 year increments. And I will tell you, looking back, I don't think we've seen a 2-year drop in life expectancy since the last pandemic, since 2018. If you look at life expectancy, it has grown consistently throughout the 20th century, except for there was this big drop around 2018. And then just in the last 5-10 years, we'd started to see it drop here in Chicago, and this is a big drop. But it's not just about seeing that drop, it's that it didn't land equally in Chicago. The biggest drops were among Black and Latinx Chicagoans. You can see in blue there, actually, the largest drop from 2019 to 2020 was in Latino Chicagoans of more than 3 years and down 12 years since 2012. So the biggest drops there. But in purple at the bottom, life expectancy remains the lowest for non-Latinx Black Chicagoans, and it is under 70 years for the first time in a very long time here. And that is really worrisome, and that is preventable, and that has to do with decisions that have been made as a city. Some of it is about healthcare access, but a lot of it is about the root causes. And so we were having this discussion. You see in red there is white Chicagoans lost about a year of life expectancy, and then Asian Chicagoans lost more than 2 years. And then what the expectancy looked like on the right there. But Black Chicagoans still a lot lower, and now 10 years gap between Black and white Chicagoans. That's up from 8.8 years in 2017. So really sobering and important, I think, to talk about and work on, and that's what we're doing. So just to go into a little more detail, we have some of this on social, but between 2019 and 2020, death rates did increase across all race ethnicities, but Latinos experienced this increase of over 60%, the steepest decline, and that population has lost that total of 7 years of life expectancy. And then we've also done a lot of surveying. We do really professional level surveying here, like the CDC would do, or it's a funded representative survey. And we always do, every year we do what's called the Healthy Chicago 2020 survey, but then we added this COVID-19 social impact survey to understand how Chicagoans were affected by COVID and related social upheaval. And, look at this. We saw 58% of Latino residents, 51% of Asian residents, 43% of Black residents, and 43% of white residents experience a job loss or reduction of income related to COVID. A lot of that has now come back, but nevertheless, knowing that income drives so much when it comes to health, right? Whether that's the ability to buy healthy food or even have access to food and not be having to put things off, to pay for medical care, to not lose health insurance if people have lost jobs. But also, stressors that come with this, bad for mental health. We see increases in things like interpersonal violence and, increases in suicide, et cetera. And so this is where we're thinking not just about the direct COVID losses, but the indirect ones. And you can see a large number of Latino and Black residents missed urgent medical appointments, and many more were needing to work in person. You can see a quarter of both Black and Latino residents worried about having enough money for housing, the basics, and 37% of Latino residents and 34% of Black residents put off paying for food. So these are the basics, and if we don't get those basics in place, you do see these impacts. Like, if you're worrying about housing and food, you're not probably thinking a whole lot about other needs. And vaccine is probably not first on your list, for example. If you go to chai.gov/COVID impact, you can see much more, including the details of how those look for white or Asian Chicagoans, as well as some of what Chicago's doing about it. Also, some Family Connects questions that come in. OneChaiFam.org, I mentioned, as part of Black Maternal Mortality Week a couple of weeks ago. We had formally launched this, but this is really One Chai Fam, One Chicago Family, is our effort to really wrap Chicago's arms around families with new babies. Check out OneChaiFam.org for more. And then Family Connects is this idea of these in-home nurse visits for all families with newborns, no additional cost to you, and it's initially available in the pilot phase at 4 hospitals, but we're really excited about this as a public health approach, and maybe we'll bring someone on to talk some more about it in the next few weeks. Quickly on COVID, if you look across the world, you still see parts of Europe, Australia, parts of Asia are surging, but it's going down overall, but still much higher rates than we've seen here in terms of cases really ever per 100,000 population, but not the huge surges in hospitalizations and deaths, again, highly vaccinated. The U.S. also continues to look quite good here. You can see the Northeast is having the most cases per 100,000 at the moment. Now, they do have a lot of testing, but they're seeing surges. And broadly, Illinois is currently at 15 cases per 100,000. Chicago and Illinois both a little bit above that at 22 and 25, but still within that low rate. And if we look across the U.S., this is just pulled off the New York Times today. Puerto Rico, I'm impressed with that curve from Puerto Rico, I will just say. I was looking at it, and they are up about 300% in terms of cases, just in less than 2 weeks. However, deaths are up like 7%. Hospitalizations are up, but just a bit. That is, if you kind of look at the curves just objectively, you sort of get a sense that that is the only one right now that is sort of looking different. That we're keeping a little bit of a closer eye on. These are the other states that have the top rates right now. So really nothing causing alarm, continuing to monitor really closely. As far as variant surveillance, everything is still Omicron. That is the top line. We did break down for you because we've got people very interested. And last week I talked more about the science of this. But all of these, BA2, BA2.1, 2.1, B.1.1, these are all just subvariants of Omicron. We have not had anything yet that is named as a new variant of interest, variant of concern, and everything is still Omicron. So no major new things there. We're going to continue to see, there's an Omicron BA, I think 0.4 and 0.5 that they've maybe picked up internationally. Typically, we've seen that when there's been a big surge, at least in COVID so far, it's emerged with something that's very genetically different. So all of these Omicrons are pretty related to each other genetically, and we've usually seen, and it's been true with Omicron, pretty good protection. Not like if you had Omicron B.1.1 and then Omicron BA.2 comes, you're unlikely to be impacted by that in a significant way as a city. So continues to look fine there, and also just watching across the country, and even in the Northeast there, we're seeing more of that 2.12. Is that driving some of what's happening in upstate New York potentially, but nothing really spreading. So we are at that low level, meaning limited impact, low levels of severe illness, and this is what Illinois looks like. There are 4 counties in Illinois that are at that medium risk, including DuPage. So just west of Chicago there, they've had an increase in case counts that has pushed them to that medium risk. We are not close to that, but of course watching and ready to change guidance if necessary. So if you're heading to mid-state or into DuPage, think about putting on a mask. It's not a requirement, but there is definitely more COVID circulating at this time there. And you can see across the country, similar to where we were seeing cases, there are, especially in upstate New York, upper Maine there's some areas that are high risk, and we absolutely recommend wearing a mask if you were to be traveling there. This is what our numbers look like by the numbers there. We're averaging in Chicago 151 cases per 100,000 in the last 7 days. If you stay under 200, it's considered low. Cook County overall is at 167. So, increased, but still not quite there. And then our hospitalization metrics are well under what would push us into medium. So that's where we are. And again, for the travel advisory, about 8% now of the counties within the U.S. have COVID levels that are medium or high. If you're medium, we really recommend considering wearing a mask, and for high risk, just wear a mask in indoor public places. And we recommend, I would not be traveling somewhere that's high risk right now if people aren't up to date with vaccines. And if you do travel, we recommend staying home, quarantining, taking tests, etc. if you go to one of those high risk settings. This is just some more background about how the low, medium, and high are determined. And this is, our cases. We're still seeing a lot of first-time and mild, even asymptomatic COVID infections right now. No major signs of concern. This is, like I mentioned up top, about the test positivity is post-spring break, coming back to what we would expect. You can see continuing that the tests declining overall, but back up after spring break. And again, this is what hospitalizations look like. It's really been low now for weeks. And this is what deaths look like, the lowest we've seen. This is our vaccination rates. We're still working on it every day. 53% now of our 5 to 11-year-olds have had that first dose, and 71% of those over 80, and all of our other age groups, over 80% of Chicagoans have had at least that first dose. And I want to give a nice shout out to the 50 to 59-year-olds. More than 95% of Chicagoans between 50 and 59 have had at least a first dose of vaccine. So if you are in your 50s, well done. And our people in our 40s are almost over 90, as are people in our 60s. So that's great to see. It really makes us worry so much less if people who are starting to get older are vaccinated, then the risk of serious outcomes is much, much less. Making progress on race ethnicity, but still seeing differences there. Black Chicagoans, though, are most likely, again, to be receiving that first and second dose of the primary COVID vaccine series. Someone wrote in and said, nobody's getting a vaccine anymore. Why do you keep pushing this? Well, we are averaging 107 Black Chicagoans every day right now getting their first dose of COVID vaccine, and another 94 Black Chicagoans completing their first vaccine series, meaning getting a second dose. And you can see the numbers, go from there. But we're doing thousands of vaccines every day here in Chicago still. And of course, the numbers are lower than they have been, but now is the time to get caught up. I wanted to just reference, the CDC has been doing some interesting analysis looking at vaccination equity, and I'm not going to take the time to go into huge detail here. Maybe we'll come back to it if people are interested next week. But you can go onto the CDC at covid.cdc.gov and explore this. And they look at this social vulnerability index. It looks at U.S. Census data, things like poverty and housing and vehicle access, about how well can a community respond and recover from disasters or disease outbreaks. And Cook County, so basically this little graph on the right here, the x-axis, meaning moving from left to right, is social vulnerability. So Cook County, and all of Cook County, is in sort of the 50 to 75th percentile, if you know what I mean, of being most socially vulnerable as a county. Parts of Chicago, of course, are in the most vulnerable, but as a county overall, we're in that, not the side you would prefer to be on social vulnerability, but then on the y-axis, the percent of the population fully vaccinated. We're also in the sort of between, percentiles wise, we're in that better than 3/4 or so of the counties. And so the further to the upper right you are, kind of the better you've done from an equity perspective. So I'm proud of where we are there. It would be even better if we got up to the top level of being at, a pretty high social vulnerability index, but in the highest level of being vaccinated. There are just a handful of counties, like 4 or 5 in the whole U.S. that are there. I'm pleased that this is some of what we're looking at and what the CDC, frankly, is looking at as they're thinking about funding and they're thinking about how we make sure cities have the resources they need to respond and save lives. Still getting some questions about transit. So yes, there is not a requirement at this point. The governor, since my last Facebook, had lifted the executive order. CDC does continue to recommend that people wear masks in indoor public transport at this time. And CTA and Metra are no longer requiring, but are recommending mask wearing. I took the L in this morning. I was wearing a mask. Actually, most of the people on the train still were. There were some people who were not, which is fine. But I prefer to, and I think particularly in that morning or evening commute when a lot of people are on, I think it can just help everybody's worry level and can contribute to people feeling secure on the train. Remember, if you see someone wearing a mask, there's lots of reasons they may do so. Be kind. People may have an autoimmune condition, have high-risk loved ones, still have unvaccinated children. I feel for those of you with kids under 5. We do think things are looking good. I'm hopeful that this summer we will be able to start vaccinating kids under 5. And people may be unvaccinated themselves or just prefer. So please continue to be kind and respectful. And actually, somebody recognized me on the L this morning, and he sort of was like, "Oh," and he said, "I don't have a mask on. I'm fully vaccinated." I said, "Okay, that's all right." I said, "Just put a mask on if you get any symptoms, if you're not feeling well, etc." But most of the people were wearing masks. And then we are still vaccinating at home. Yes, we are not planning to drop this program anytime soon. 312-746-4835 or chicago.gov at home. We will set up appointment for you Saturday, Sunday, Monday, or Tuesday, 8 a.m. to 6:30 p.m. We'll bring up to 10 people. There are booster doses available. Anyone over the age of 5 in Chicago can get this at home. We'll do Pfizer pediatric adult first or second boosters. And then in certain zip codes, we continue to offer that $50 gift card for first and second doses of a primary vaccine only. So, and those are the zip codes on the right. Any questions? That's also the number to give us a call. We'll figure out whatever your need is related to COVID, and then that's our website. Okay, so that was longer than usual in terms of me talking, but we're getting a lot of the same kinds of questions in, so hopefully that helped address it. And let me turn now to some of your questions. Oh, someone noted that the roundtable discussion, it's not on the mayor's page. Okay, sorry about that. It was recorded though, so we will post it on our website when it's available. So it'll be at chi.gov/COVID impact. So that's the same place. Chi.gov/COVID impact is where you can explore more of the data. We'll make sure it's posted up there. Sorry about that. And also, if you're not aware of the Chicago Health Atlas, chicagohealthatlas.org is where you can go to really look at a community level, the most up-to-date data we have for a lot of these underlying conditions, and you can map how some of the social vulnerability overlaps. So check that out if you're interested. All right, Lisa on Facebook. I'm surprised to see COVID-19 not being the #1 cause of death in 2020. Was that right? Did it surprise you? So, and if it is, what is CDPH doing to address heart disease and other chronic diseases? Yeah, so, it's always really interesting. The chronic diseases, meaning the heart diseases, the diabetes-related diseases, some of the cancer-related diseases, those are always the biggest killers, always. But they tend not to get attention in the same way that infectious diseases or outbreaks or diseases that are more associated with an event, like homicide or an overdose or even a baby's birth. Because those diseases that are sort of there with us all the time, it can be easier, I think, for people to not take as seriously the risk that they pose. So, as you know, I'm a primary care doctor. So I take care of people who have high blood pressure. I take care of people who have diabetes. And when you have high blood pressure, you don't feel bad for years usually. But over many years, if you have high blood pressure, you end up with potentially developing heart failure. You end up potentially developing, there can be risk factors that run along that can make you more likely to have a heart attack, for example. And if you don't work on treating the blood pressure before it becomes life-threatening, it's harder to do something about later. But by human nature, we don't worry so much about things that feel like they're there all the time. It's one of the biggest problems of having people understand public health. When it's working well, you don't know we're there, right? There is no outbreak at the restaurant. There is no problem with your drinking water. You don't have lead-poisoned children. There's not huge pandemics, et cetera. So to address some of these heart disease and chronic disease, one is just, yes, it is, even during COVID, the number one cause of death was heart disease. And that is true every year in Chicago. It is true every year in the US. And a lot of that has to do with obesity. It has to do with some genetic factors. But a lot of it has to do with things like, do people have access and choice around healthy foods? Do they have safe spaces to be able to go out and exercise in? Do they have ways to take care of stress, knowing that can impact health, et cetera? So we are funding through the Healthy Chicago Equity Zones, actually working on specific things there. There's diabetes sort of prevention and education work that we are part of across the city. But a lot of it is about really thinking not always about health as recovering after some acute event, but that preventive piece of it and the systems and environments that the health department is part of. Okay. All right. So, all right, so there's some questions. I'm just looking sort of through. Faith State, Kristen Korkowski, and Kathy Vase-Vinsberg on Facebook are all asking about, situation with CTA and masks. Will masks come back? Are you still wearing your mask in most situations? So Kathy asked, am I wearing my mask in most situations? So I am not wearing my mask in, quote, most situations. When I am at home, when I am at work, for the most part, I'm not wearing it. But if I am on the L, or if I am in a setting that feels a little less controlled, I continue to be just a little bit extra careful from a COVID perspective. I have older family members. I also obviously want to make sure I can not be interrupted from, doing my work and the work of the health department. And so I am just a little bit extra careful, but it's not like I put on a mask every time I walk into a building. But in a setting, and especially I'm just like, do I think it might make people feel more comfortable for me to be wearing it? So I have been to some, larger events at this point where nobody's wearing a mask. Those tend to be ones where everybody is vaccinated, though. I do feel more comfortable in those settings. If it's a setting where I don't know folks, I don't know their vaccine status, I don't know their current health status, especially if I am not really able to keep that distance, I might just pop it on. I also think it can help people who may be immunocompromised or have unvaccinated children, et cetera, just feel more comfortable. So I'm thinking about sort of who's around me, too, when I think about that decision to wear a mask. And I think, Faye, I already answered your question with the CTA and masks. Not required. They do continue to encourage it, as does the CDC, and many folks continue to wear it. All right, a couple of booster questions let's get to. Jesse Akins on Facebook, do we need a second booster over 50 years old? Patty Graff on Facebook says, I've had 4 Moderna shots now, the primary series and 2 boosters due to my age. Good. I understand the boost is minor, not long lasting, and maybe there's a variant being developed for fall. How many vaccinations can be safely administered? I worry about heart-related inflammation. Okay, another good question. And then Matt Robertson on Facebook, I work in retail. I've had both doses of the vaccine and 1 booster. Should I get a second booster? So, all right, let's talk for a second about boosters. So, Jesse, to your question, everybody is recommended for a first booster, to be clear, everybody over 12. So if it's been 4 months since you've completed your first and second doses of whatever COVID vaccine you got, I would definitely recommend getting that first booster dose. The second booster, which was the more recently one available, does not have as strong of a recommendation around it, but CDC did make it available. FDA authorized it for people over 50. And what we've basically said, looking at the data, is that there doesn't seem to be a downside to doing this, to be clear. So to Patty's question about worrying about heart-related inflammation, I would not have a concern about that. Vaccines, and particularly when you're getting boosters of vaccines you've seen previously, especially in folks who are older, I would have zero worry, honestly, about heart-related inflammation in somebody getting an additional booster who is older. To your point about the boost is perhaps not long-lasting, I think that is true, and that is one of the reasons why the recommendation was narrower there. That the idea of providing extra protection, you do get a boost, like no doubt about it, back up in your antibodies, and if we were to see a surge right at this moment, you would want people to be as protected as they could be. I do think, I don't know for sure, the science is very much, the scientists are still working on, will we have a vaccine perhaps in the fall that may be more universal, that has been adapted to be more responsive to some of the newer variants. That might be a more of a universal recommendation again. But otherwise, back to the original question, do you need a second booster over 50? You don't need a second booster over 50. I would say personally, if you're over 50 with an underlying condition, or you're over 50 and you're in a really public-facing job, or you're just worried about it, I would get a second booster. And if you're over 65, I really would get a second booster. Again, I don't see a downside. You get a little bit of marginal additional protection. But if you're really feeling strongly about not doing it, I think that's okay. The most important thing, no matter what your age is, if you're worried about COVID, is does everybody around you, are they up to date with their vaccines? And up to date actually just means first, second, and then the first booster when they're eligible. So I hope that helps clarify it. All right. So Tom Seifert on Facebook, will J.B. Pritzker reissue his disaster proclamation for another 30 days? Okay, so I can tell Tom has been following this closely. So there have been these sort of disaster emergency declarations that have, that allow, for example, us to spend COVID funds on COVID in faster ways. There's been the ability to meet remotely for public meetings, things like that. And so there have been reasons to continue to extend that state of emergency kind of administratively. I don't know, I'm not the governor, but I do know there's sort of I'm seeing sort of a second question here asking about, if the emergency order, the disaster proclamation did not get renewed, does that mean there would be no setting in which masking would ever be required? So, no, because if there is a specific setting, the emergency things that have been in place in COVID are around the public health emergency. Completely separate from COVID, the Chicago Department of Public Health, for longer than the city of Chicago has been in existence, right, has had sort of the legal authority to require isolation or quarantine. So, the Board of Health for the city of Chicago, the precursor of CDPH, actually literally is older than the city of Chicago. Before there was a city of Chicago charter, there was a Board of Health, and it was formed in large part to be able to quarantine people who were coming in off ships on the Great Lake. You were concerned about cholera, et cetera. So very deep in the Communicable Disease Code, in the Illinois State Code, and city laws, et cetera, there is the ability for us to require isolation or quarantine, as an example. And so just to kind of play that out a little bit, let's say there's somebody is diagnosed with COVID and they are in a setting during a time that they might be infectious. So we know that COVID for the first 5 days, you need to be isolated because you can definitely be spreading COVID at that point, and then you need to be out in days 6 through 10, with that mask or whatever. And if somebody said, you know what, I don't want to ever wear a mask again, then CDPH, separate from any governor, emergency order, et cetera, has the authority and could use that authority to issue an individual quarantine order. Or that would be an individual isolation order if somebody is sick. A quarantine order would be if somebody has been, has had this high-risk documented exposure. So we don't like to have to do individual level, court requirements around isolation or quarantine, but we do it when we have to, and we've done it before COVID, and we would again if there were a need for it, more at an individual level. I think broadly the recommendations around isolation and quarantine, for the most part, do not end up needing to be legally enforced, but we have the ability to do that regardless of whether the governor's order is in place. Joseph Anthony on Facebook. The vaccines don't stop infection or transmission, so why vaccinate at all? So first of all, the vaccines you are correct that they do not stop infection or transmission. However, do they, number one, reduce both infection and transmission? Absolutely. And most importantly, they turn COVID from a disease that kills, 4,200 people almost extra people in the year 2020 from COVID into a disease that is putting very few people in the hospital at this point. So we vaccinate, number one, to protect ourselves. When somebody has been vaccinated, it is the most important thing, if you look at the data, the most important thing for helping to protect against severe outcomes, especially hospitalization and death. Your best protection out there is if you have both recovered from natural infection and been vaccinated. And it looks like the order of those, there are still some studies about this, but the highest level of antibody, this is some of the best science, going back a year and a half where they were taking bone marrow and all the rest of it. The best level of protection is that combination of people who had COVID back, in the early days and then were vaccinated, or were vaccinated and then perhaps had a more mild breakthrough infection. That's the best protection. But we don't want people just going out and trying to get COVID to sort of build their immunity. That is not smart because you can, there's the long COVID that we're still learning about, but also it's not like when you get COVID, you're never going to get COVID again, because we have seen very clearly that as new variants emerge, that quote protection from earlier really doesn't seem to hold up. However, the protection from the severe outcomes from vaccination has held up really, really well. But it's not just about that individual. So that's the most important thing. But the other thing is that if you look at the data, the chance of actually getting COVID, meaning transmission, right, in these higher risks, in any setting, and of spreading it, the number one thing that helps cut that is also being vaccinated. We did a study, for example, right here in Chicago, a really good study looking at household contacts, the highest risk setting that we've got. And as Omicron was coming and we could do some of that genetic testing, we offered it to folks in households because you can see, is that spread at that time when you have a new variant, you can actually understand a little more about spread pretty easily. And we saw that, where people were masking, where people were vaccinated, both of those cut significantly the risk of transmission, even in that highest risk setting of the household. And so no vaccine is perfect, but thank God these vaccines work as amazingly well as they do for severe infections, and they do help. They do cut the risk for both transmission and infection. A multi-layered strategy, we talk about this Swiss cheese, it's about vaccination, then if you need to, adding masks, distancing, ventilation, all of these things together help decrease risk. None of them completely eliminate risk, but vaccination is absolutely at the core and the most important thing to protect at the population level. All right. Still a bunch of questions I didn't get to. Amanda DW on Facebook. How worried should parents be about the hepatitis outbreak in kids? So for those who aren't aware, there have been a few individual cases of this unexplained, really serious hepatitis. Hepatitis means liver inflammation by definition. And people might know hepatitis is hepatitis A or B or C. That's caused by a virus. And you can test and say, oh, this person has hepatitis A, B, C. you can have foodborne illnesses, hepatitis that can carry that. There are lots of things, different viruses, different inflammatory things. Lots of things can cause hepatitis. There have been cases, though, of really severe hepatitis, like where a child needs to get admitted to the hospital, even have a liver transplant, without a clear cause. There have been 3 of them in Illinois. 2 were in suburban Chicago and 1 further downstate. There have been a handful across the U.S. The leading theory is that this is linked to an adenovirus, which is a pretty common virus that can cause usually just common colds, but that seems to be what's consistent. At this point, the CDC and CDPH and IDPH have just asked, if clinicians are seeing children with really severe liver inflammation without a known cause to reach out, and then we help with that investigation. CDC is looking at this, but I don't think you need to be seriously concerned. There's nothing at this point that is suggestive of a major outbreak that's linked to something that is people are eating or drinking. If it is an adenovirus, and there's more to say there, we of course will share it. But at this point, you don't need to change behavior. Have your kids continue to wash your hands, and some of the masking and some of the staying home when you're sick, all of that we're doing sort of around COVID. It also helps protect against the spread of these other diseases. But we'll let you know if there are additional other concerns there and keep you up to date. And I think there's a couple. I know we're just about at time. I do want to take 2 of these questions, though, from people I think who are sort of trying to poke a little bit, and I want to address it. So Joseph Anthony on Facebook says, why are people who are dying of, quote, COVID only doing it in hospitals? Might it be a deadly combination of morphine, remdesivir, and sedation to induce coma and vents, etc.? Might it also be intentional misdiagnosis and subsequent treatment because of how well, quote, COVID plays through the CARES Act? Can anyone tell the difference between the flu and COVID if not for these fraudulent tests and fraudulent diagnosis? Try testing an orange or a lemon if you don't believe me. If you are instead labeled as having pneumonia, your chances of leaving that hospital alive go up exponentially. Same symptoms, they label you COVID, and you will be lucky to get out alive. This has to be investigated and changed. Everyone's life is in danger in a hospital today because it pays so well. So, Joseph, I appreciate that comment because there's just a whole lot in there that is not, it's not based in fact. And I'm interested in where you're getting some of that information. So let me just quickly, because if there are others who are watching, let me just hit on a couple of things there. So first of all, there are absolutely people who die of COVID who never make it to the hospital. This is why the medical examiner tests people who are found down. Do they have COVID? And in fact, we had a problem, especially early in COVID, with undocumented folks who were Latino, for example, never calling 911 and actually just dying at home of a respiratory illness from COVID. So there are people who die of COVID, but not in the hospital. That is a real failure on a lot of levels, in my opinion. But most people who get COVID, get pretty sick, and they end up needing to go to the hospital, the emergency department, whether they can or they can't. And you never, ever, ever put people sort of into a coma or on a ventilator unless they have an underlying condition that requires it. And so the sedation to induce the coma, the morphine, that is not what kills people. And there is not intentional misdiagnosis. And this idea that hospitals or public health, that like somehow doctors or hospitals or CDPH like gets more money if more people die of COVID, it's not a thing. In fact, the hospitals, it's been really interesting where I've looked at outcomes. Some of our very best hospitals, here in Chicago and even across the country, that really stepped up during COVID, took a lot of the sickest patients in who needed that ICU level care, really saved a lot of lives, took a bath financially because we don't reimburse very well for people who may need that sort of long, like ICU care where you're sort of saving somebody's life. We reimburse better in this country for things like outpatient, orthopedic procedures, more elective procedures. And when those needed to go on hold, the financial model for hospitals did not go well. So there are not there is no incentive to sort of make up COVID diagnoses. And can anyone tell the difference between flu and COVID, if not for fraudulent tests and fraudulent diagnosis, and you recommend testing an orange or a lemon? So I don't know if you mean like testing the juice of an orange or a lemon. Test the juice of an orange or a lemon. You will not get a positive COVID test, I promise. So I don't know where you're getting that idea, but if you have read that somewhere, I encourage you to do the experiment for yourself. You cannot tell the difference between flu or COVID without a test, but the tests are literally looking for the genetic material, the antigen response, and they can tell you the difference, but you have to get the test. It is a waste of a test to use it on an orange or a lemon, but if that helps you believe the test, like, go for it. I wonder sometimes where where that idea is coming from. And so finally, I think I'll just say, you say if you're instead labeled as having pneumonia, your chances of leaving the hospital alive go up exponentially. Pneumonia is kind of like hepatitis is inflammation of the lungs. Pneumonia just means infection of the lungs. So you can have a pneumonia that is caused by COVID. You can have a pneumonia that is caused by strep bacteria. You can have a pneumonia that is caused by many things. Pneumonia is actually a symptom. So you can die of pneumonia that the underlying cause of it is COVID, or you can die of pneumonia that the underlying cause of it is, any other infectious disease. And so a death certificate, when we talk about people dying from COVID, that is because they get certified as like COVID being the thing that kills them. And we talked about this in some detail. If you go back in the archives, how many of these are the primary diagnosis versus an underlying diagnosis. But when a doctor is certifying that someone has died sort of as a result of COVID, it's because of COVID, and they may have died from pneumonia even with COVID. So you can say someone died of pneumonia with the underlying cause COVID or the underlying cause not COVID. And thankfully, our outcomes have gotten a lot better as we've learned how to take care of people with COVID here in the hospital. So everyone's life is in danger in a hospital because it pays so well. It just worries me because it makes me worry a little bit for you, Joseph. Like, if you get really sick, like, I don't want you to be one of those people who dies of COVID or anything else because you don't trust a hospital, right? If you're having a heart attack, you need to go to the hospital. Like that, the hospital's goal is to save your life. I know we're a little bit over on time, but I wanted to run through all of those because it just highlights all of the misinformation that continues, I think, to circulate. So thank you, though, for putting that in and putting the comment. It gives me a chance to address it. And if there are documents or websites that you'd like to point me to, I'd be more than happy to look at them and address them. But I hope, I can't, I'm glad you're watching too, frankly, because, it's interesting. And I'm glad where there has been such a lot of a lack of trust that has built up, that you're still paying attention, even if you're coming to ask those kinds of questions. So thank you for raising that. And if you do the orange lemon experiment, let me know, because I know how it will turn out. Okay. Maybe the very last question, Jason Guthars from Twitter says, why is @Chi Public Health, @Chicago's mayor, providing $50 gift cards to people who get the first or second dose and not a third or fourth when we know vaccine effectiveness against COVID-19 or Omicron infection rapidly wanes? So a couple reasons. Number one, and most practically, is that those $50 gift card incentives are with some CDC funding that actually is limited to first and second doses. So we are not allowed to use the CDC funding to do booster doses. So that's sort of the shortest version of that. But the other reason is that the best protection, the best increase in protection comes when people get that first vaccine series. The booster, especially that first booster, definitely helps. But then, as you've heard, even that fourth booster, there's additional protection, but it is a diminishing return at this point. It's important for people who are older, more likely to have the severe outcomes. But until we get a version that, if we need a version that has been more made for the variants, then that could be something that we're again recommending. But in the meantime, I am the most concerned about the community areas in Chicago that still only half the people have had that vaccine. And we saw what happened during Omicron. Those were the community areas, a lot of them predominantly Black, that had the most hospitalizations, the most deaths. Being unvaccinated meant you were more than 20 times more likely to die during the Omicron surge compared to folks who are, vaccinated and boosted. And that was regardless of whether somebody had had COVID in the past. So I don't get any money regardless of when you get, how many people in Chicago get vaccinated. I don't know where that idea has come from. My goal is to work on Chicago's life expectancy, the health of the city. I wish I had a vaccine for opioid overdose. I wish I had a vaccine for infant mortality and gun-related homicide and heart disease. I wish I had a vaccine for HIV, but we don't. But we got one for COVID. And so turning that into something that doesn't kill people as much as possible, the easiest way to do that and the safe way to do that is to join the more than 5 billion people around the world who have now had their COVID vaccine. So thank you all for your questions. I appreciate some of you are writing in some comments about that last question, and I see those and appreciate the support. But I'm glad that where people have that much mistrust, they're watching, actually, even if they're watching mostly to try to poke holes. So we will be back next Tuesday at 11 a.m. per usual. And you can also write in and let us know if there's particular topics you'd like us to cover as we have more time to talk about not just COVID and all of the things that Chicago has, both exciting things on the health perspective as well as all we're trying to do to address the life expectancy gap. Thank you for your attention, and we'll see you back next Tuesday. Bye-bye.